It's the open abdomen, which is kind of a great, it straddles trauma and emergency general surgery. So it's a good way to introduce EGS to everyone. So without further ado, Dr. Cordova.
All right. First of all, thank you, Dr. Schetz. Thank you, everyone, for your attendance, both in person and virtually. Thank you for the undeserved opportunity to give this inaugural talk for the EGS program, seeking our verification through the American College of Surgeons. For those that don't know me, my name is Alfredo Cordova. I have a clinical appointment through FSU. I have the privilege to serve in the Army Medical Corps. Recently recruited to the 75th Innovation Command. Very excited about it after 10 years of being in a combat support hospital. So it changed here, but it didn't change there. There you go. A little slow. So I wanted to introduce you guys, first of all, to the Excelsior Surgical Society. It's a military society within the American College of Surgeons. It's not new. We actually recently celebrated the 80th anniversary, and we had to travel. It was all work related. We traveled to Rome to celebrate the 80th anniversary of the creation of the society, as well as the 80th anniversary of the end of World War II. And this is a recreation of the picture that was taken 80 years ago in the same hotel, in the Excelsior Hotel. And I'm back there in the very back of the crowd. As I mentioned, it was all work. We were only working. We didn't do any sightseeing, but we did have the opportunity to visit Anzio. Anzio is a beach 30 miles south of Rome, where the Allied forces landed in order to take back Rome. And this is 80 years ago, and these are a little more peaceful times. A couple of weeks ago when we visited, we had the presence of the unnamed soldier throughout the conference. And another picture of the group. It was an interesting crowd. There was Surgeon General from Switzerland, from Israel, also from the UK, as well as other allied forces, including Canada and many other countries. And we also had the opportunity to visit the Sicily Rome cemetery, where nearly 8,000 of US soldiers are buried. And as we can see, there's soldiers from all religions. I was able to spot a Medal of Honor. And I wanted to just show a picture of Sergeant Antolak, who is resting in peace south of Rome. And there's, as I mentioned, nearly 8,000 soldiers, and the average age of the soldiers is 20 years of age, the oldest one being 49 years old. So we can only assume that most of them were 17, 18, so very young. And this statue is very representative of the brotherhood within the different armed forces. So before we get into that topic, I'm still in the branches of everything. I want to introduce a little bit myself. Thank you for that kind introduction. I'm originally from Lima, Peru. And this is my hood. This is where I grew up in Lima. It's called also the City of the Kings because it was founded on January 18th of 1535. That's when the three kings went to visit Jesus Christ. Also called a garden city, even though it's in a desert. It's very green and very colonial style. There's a church pretty much in every block. It's a beautiful city. We have one of the seven wonders of the world, Machu Picchu. It should be on everybody's bucket list. And also the Amazon is born in Peru before traveling through Brazil and emptying into the Atlantic. And we have majestic creatures like jaguars, condors, and beautiful traditional dressings, as we can see here, being worn by these kids. And this is Rio, it's the Rainbow Mountain, where thanks to Mother Nature and the mineral deposits, like this mountain really looks like a rainbow made of different colors. And for you guys who haven't tasted Peruvian food, it is completely out of this world. I can make pisco sours, lomo saltado, and these deep Parmesan clams. And the food is just amazing. Last year, 2 of the top 10 restaurants in the world are in Lima. So visit Lima, visit Peru. It's going to be a great experience. And if you can get something out of this lecture, there's 4,000 types of potatoes. And you can probably find all of them if you visit Peru. And this is where I grew up in Peru, and I'm a slow learner, so I have a pretty non-linear training. I went to medical school in Peru, and this is where I did my internship. It was founded a long time ago, 1549. It's one of the oldest hospitals in America. Just to put things in perspective, Bellevue Hospital, the oldest hospital in the US, was founded in 1711, I want to say 17 something. So much earlier. And it's a more spread, the buildings are more spread. This is a ward, and whenever you enter the ward, you can you can check your 40 patients that you may have. I don't think you have hospitals like this in the US anymore, which obviously takes away the privacy for patients, but you can pretty much screen your patients from the doorsteps who may be doing well and who may not be doing well. When I came to the States, initially I did vascular surgery research, and then I did my surgical residence at Detroit. You truly learn to love the D. Before going there, I told one of my biggest mentors, and he told me, you're going to get great training. You're going to the murder capital of the world. And he was absolutely right. There's a guns and knife club every single day of the week. Then I did my burns and reconstructive fellowship at Hopkins and my surgical critical care fellowship at the Brigham. So enough talking about me. Let's talk about EGS, and let's talk about open abdomen. I have no relevant disclosures aside from being a dogs and sea turtle lover. I am a consultant for Kerecis, Avita, and Polymedics, but again, not relevant for this talk. So these are our objectives. We want to, first of all, recognize what's the lethal triad. Recognize so that we can treat it potentially with a damage control operation and surgery. We also want to be able to recognize those risk factors of abdominal hypertension, abdominal compartment syndrome, so that we can treat it with a decompressive laparotomy and other strategies that we're going to discuss. And we're also going to discuss how to manage the open abdomen and how to manage and do a abdominal repair, a stage abdominal repair of that defect. And I think you guys have already been successful in learning how many types of potatoes exist in the world. 4,000, just as a reminder. So open abdomen was originally described already quite a while ago. It was first described by Dr. Ogilvy, who was a military surgeon. And we can see him there in the picture. And he wrote in the Lancet back in the 1940s, a little bit over 80 years ago, a description of how to manage an open abdomen. And he mentioned that he would control an open abdomen with light canvas or cotton cloth, sterilizing Vaseline, make a double sheet of it, and then contain all the viscera by suturing that canvas to the abdominal wall with interrupted catgut sutures. So everything starts with abdominal pain. So what is an acute abdomen? Not to be confused with acute peritonitis, and many times we use it indistinctively. Acute abdomen just refers to severe abdominal pain. And a sudden onset of severe abdominal pain And it's certainly a frequent problem. It constitutes 10% of all ED visits, and up to 40% of them may require surgical intervention. It's important to know that 1/3 of those cases may present with the typical symptoms, sometimes a pneumonia, a pleuritis, pericarditis, even an MI may present with even abdominal pain. So we should have our spidey senses on alert and not get confused about it. Some of those clinical etiologies that may be causing an acute abdomen and potentially may require surgery include inflammation, infection, hemorrhage, blockages, as well as perforations of all sorts. And depending on the region of where the abdominal pain is, we can have an index of suspicion of what may be causing the overall problem. This is our some of the differential diagnoses of some of those conditions that are medically treated that can really present with very impressive abdominal symptomatology that it can fool any expert physician, including ourselves, the surgeons. So some of them may be diabetic crisis, sickle cell disease, porphyria, lupus, and poisoning of all sorts. This is our playground, or the geography that we work with, the abdominal cavity and the peritoneal cavity. And this is how acute peritonitis may look initially with inflammation throughout the abdominal cavity. It's also going to look very angry looking. If we ignore it long enough, it's going to become very sad looking like this. Yes, fibriness, if all these valves were soaking or just laying on stool or sockets for a prolonged period of time. Certainly, in all these cases, there's a extensive or significant systemic inflammatory response that just leads to a cascade of events affecting pretty much every organ in our body. So we never want to operate just on an X-ray, but here clearly we see two very bad problems that are actually a pretty ominous problem when we see such extensive portovenous gas, and we also see this pneumoperitoneum or free air. So this patient likely has pretty extensive bowel ischemia, gangrene, and even perforation. So just to try to be a little graphic about this, we have you can have all sorts of perforations, peptic ulcer disease, here gastric ulcers, duodenal ulcers. This was in the fourth portion of the duodenum. Also, dead bowel from different etiologies. In this case, a closed loop bowel obstruction from an internal hernia. Also, we can see here somebody with a massive sigmoid volvulus, or somebody with extensive bowel gangrene from a cecal volvulus or just bowel ischemia. So in all these cases, this patient may come in extremis, very sick, and it's important to recognize how we're going to treat them, how aggressively we're going to treat them, just to also initially set up expectations with family, with the patient, as well as just to have our surgical plan of how we're going to manage them. It's important to understand the lethal triad. And we're going to talk about it a little more in a second. And also we're going to talk about the phases of damage control surgery, which are 4 phases. Initially, damage control resuscitation, then the surgery itself, just to control the contamination, control the bleeding, then take them back and restore the physiology of the patient. And then later on, when the patient's physiology has been completely restored, at that point, perform a definitive surgery, which may include bowel anastomosis, closure of the abdomen, feeding tubes, as well as ostomies. And we're going to talk about how to manage that open abdomen that we've been talking about for quite some time. So let's go back to World War I. Back in World War I, the Imperial Germany Navy was pretty successful in keeping their fleet afloat despite being significantly bombarded, bombed, or attacked. In 1948, the U.S. Navy was pretty impressed and wanted to emulate those and they are the ones that first coined the term damage control. And that refers to be able to, the capacity to absorb damage and maintain mission integrity. We may recall back in 2017, the USS John McCain, when he was navigating the coast of Singapore and Malaysia, he was hit by a Liberian tanker. Yet there were casualties. I think like 10 people died, but he was able to maintain its mission. I think 2 months prior, another U.S. destroyer was also hit by a container ship. So this is what some of us were doing back in the 70s and 80s. This is how we went our clothing for workout. There was a love and hate relationship between Russia and the US. I think they call it the Cold War. And some of us were hitting the dancing floor in the disco times, and we acted or looked like that. At the same time, surgeons in the operating room tended to perform very heroic operations, long and complex. At the end of the case, everybody was high-fiving each other, and they were technically perfect procedures. However, people were dying, their outcomes were terrible. Later on, we found out that it was just because of issues that we're going to discuss. So back then, surgeons were performing extensive resections, extensive reconstructions. They were losing a lot of blood. They were giving back a lot of blood and a lot of fluids. And that was not helping our patients. Dr. Ken Mattox, that is a very prominent trauma surgeon, still alive and has a yearly conference, which many of our members of our team are going to be attending this year. He wrote a book, Top Knife, highly recommended to anybody interested in surgery. And he, quote unquote, he mentioned, it requires more sound cognitive judgment to determine operation. Dr. Richardson, in that same book, mentioned that it's judgment, not genital insufficiency, that leads one to pack a patient. So in the 80s, many surgeons throughout the country were staging some of their trauma patients. They were either packing the patients, leaving their abdomen open. They were anecdotally having these discussions in trauma and surgical conferences. And there was already curiosity about staging some of these patients that present on extremis. And this will later on extrapolate also to emergency general surgery and other specialties as well. The theory behind what it was being done back then goes back to the early 1900s, when Pringle was already reported a series of patients. I think there were something around 10 patients in which he packed them and had a better outcome than those that were just undergoing a definitive operation. Also, Charles Lucas from Detroit, in the 1970s, he published a series of 600 cases in which he also packed some liver traumas. Similarly, in the late 1970s, Kane published another series of liver traumas which were being packed prior to being transferred to another facility. Stones then mentioned about or reported about the benefit of staging an operation. He reported a series of 30 patients in which those that were packed and staged had a survival that was significantly higher than those that were just undergoing the standard treatment of the time, which was a definitive surgery. We're going to do the math. So there's definitely more than over 50% survival in those patients that were staged. Rotondo from UPenn, he coined the term damage control surgery back in the 1990s, in the early 1990s, when he showed a 7-fold survival improvement on patients with major vascular injuries. He showed a 77% survival on those treated with damage control surgery
Well, just so we get
versus
to-
only 10% survival on those treated with definitive laparotomy.
No.
So this is a lethal triad, and this is what's going on with these patients that were potentially treated with prolonged and heroic operations. Acidosis, hypothermia, and coagulopathy that combination carries an over 90% mortality. And that occurs because when this happens, there's going to be a multi-organ failure, platelet dysfunction, cardiac dysfunction, as well as arrhythmias and so forth.
That's everything.
So these are the critical factors to recognize on our patients on extremis: severe metabolic acidosis, hypothermia, prolonged operative times, coagulopathy, patients that receive massive amounts of blood if they have bleeding, or patients that receive massive amounts of fluid resuscitation if they are, for example, an EGS patient. More than 10 to 15 liters of infusion in 24 hours may put them at risk of developing abdominal hypertension and potentially progress to abdominal compartment syndrome. So just to go
sent two
again to
different
the
links.
phases of damage
click on
control
the link,
surgery
click to
or
one place,
operation, initially it
doesn't work,
requires
and then the phone link
a
didn't do a phone, but I
recognition
can't see
of
it.
the altered physiology to recognize those critical factors that we just described.
I'm just gonna-
After the patient has been expeditiously
I haven't seen these.
optimized, taken to the operating room in order to control contamination, control hemorrhage, and also to secure perfusion, potentially with stents. Then the patient will be taken back to the ICU, and the physiology should be restored. The patient should be warmed up, acidosis corrected, coagulopathy corrected. And finally, it could be 12, 24, 48, 72 hours later when the patient's physiology has been restored. At that point, you start to think about doing definitive operation, including anastomosis, feeding tubes, ostomies, abdominal closure. But again, not sooner than that. So this is mainly pertaining trauma patients, but potentially also some EGS patients like hemorrhagic pancreatitis. It's okay. Permissive hypotension, meaning systolic pressures of 70 to 80, as much as it may make everybody a little uncomfortable. Early use of blood products and following the 1:1:1 ratio. Minimize crystalloids, early correction of coagulopathy, consider TXA, and the viscoelastic studies, Tago, Roten may certainly be a nice adjunct to know how to replace those blood products. So here's a picture from Dr. Holcomb, John Holcomb, who showed a nice changes that occur from how we manage patients in the early 2000s to how we manage patients now or as back as 10 years ago. Remember when I was in residency, everybody automatically got 2 liters of crystalloids, doesn't matter what they were there for. And in these 2 cases, they both sustained similar injuries, penetrating liver injury, and they were both treated with similar amount of packed red blood cells. The main difference is that one of them was treated with more colloids, and that one that was treated with more colloids was treated with less crystalloids compared to this. This is how the bowels looks 24 hours later, completely edematous. There's no way that this abdomen will be able to be closed, and if it's able to be closed, the patient will definitely develop the abdominal compartment syndrome. In this case, the bowel is not as edematous, and this patient will likely be less challenging to close. So phase 2 of damage control surgery, the operation part. Again, contamination control, hemorrhage control, perfusion of vital organs, and do not plan of doing any definitive operation. So restoring blood flow, potentially shunts or stents may be needed. on extremities that may be bleeding, they may need to be amputated, or tourniquets may need to be applied, or vessels may need to be ligated. On any hole that there may be anywhere in the body, either resect or fix that area. But and in these cases, do not consider doing any anastomosis, placing any feeding tubes, or doing any ostomies. After that surgery is completed, the abdomen may be temporized with a temporary closure, and we're going to talk about that in a minute. The patient will then go to the ICU, gets its euvolemia, or gets its volume status, there's temperature, acidosis, and coagulopathy restored. When that's accomplished, then they come back for definitive surgery, which will include anastomosis, feeding tubes, ostomies, and hopefully you're able to close the abdomen. So what's abdominal hypertension? So most of us, we have an intra-abdominal pressure of less than 10, typically between 3 and 7, unless we have a huge meal, and maybe a little bit higher. When it goes more than that, 10 to 25 is considered intra-abdominal hypertension, and more than 25 may be considered abdominal compartment syndrome. And it's a syndrome, so it doesn't necessarily need to be 25. It could be with a lower pressure than 25, that the patient may be showing signs of hypoperfusion, both intra-abdominally as well as systemically. Abdominal compartment syndrome and abdominal sepsis are life-threatening conditions and carry a very high morbidity and mortality. They require an immediate action consisting of decompressive laparotomy. This is Dr. Krohn back in the 1980s, where in animal models, he was able to show that intra-abdominal hypertension will lead to a decreased perfusion of the kidneys. This was replicated by other scientists, again in animal models. Dr. Krohn himself, in a series of 11 patients that sustained aneurysmal disease, an aneurysmal rupture, he found that those that postoperatively had an intra-abdominal pressure of more than 30, the ones that were decompressed survived, and the ones that were not died. That definitely called the attention of many people, many surgeons. There was a lot of excitement. Back 20 years ago, an abdominal compartment syndrome society was formed, the World Society of Abdominal Compartment Syndrome. If you're very interested in the topic, you're welcome to join. It's free to join. The annual dues are $0, so the price is right. And they came out with a consensus and practice guidelines. This is a definition of intra-abdominal hypertension, and the definition of abdominal compartment syndrome is more than 25, with, again, signs of hypoperfusion. There's 3 types of abdominal compartment syndromes. The primary, when the process occurs in the abdomen. Secondary, when the process occurs somewhere else, some other systemic infectious disease. And the tertiary, when it's a recurrent abdominal compartment syndrome. So this is the pathophysiology of abdominal compartment syndrome. First of all, the patient has some critical illness. Requires, the patient may be hypovolemic, in shock, may require massive fluid resuscitation. That's going to lead to significant bowel edema, mesenteric edema, ascites, and asarca. That's going to increase the pressure in the abdomen, leading to more bowel edema. That's going to also lead to a decreased perfusion to the kidneys, decreased perfusion to the gut or the bowel. Also may cause compression of the vena cava, leading to decreased preload, decreased cardiac output, and there goes the vicious cycle. So it's important to recognize it so that we can treat it. And the way to treat it is with decompression. So this is what the quote-unquote shock gut looks. Very swollen bowel, significant bowel edema. Subsequently, this is a patient that had a ruptured AAA, and after the massive resuscitation that he underwent, now, well, he has already there's already granulation tissue over the omentum or the valve. It can be grafted, but obviously there will be absolutely no attempts to try to close that abdomen. The early management may consist of, as Dr. Ogilvy suggested, just Vaseline, gauze, or a cotton cloth. Some newer strategies include negative pressure wound therapy and some of the dynamic closure systems. These patients carry a higher risk of easy fistulas, loss of the mains, hernias that are going to be certainly challenging to fix even later on when the patient is completely recovered. So this is a patient that was a burn patient, sustained like 40% total body surface area burns based on Parkland or Brooks. They will get significant fluid resuscitation, and in the ICU, they develop hypotension, oliguria, also coagulopathy. Clinically, he got abdominal compartment syndrome. A way to assess this, instead of measuring intra-abdominal pressures, is more effective to measure bladder pressures. Basically gets connected to a transducer. And we did he was once able to go to the OR, so patients that can be in extremis, they may need a bedside laparotomy. So this is a study in which we see the benefits of these patients with abdominal compartment syndrome after a decompressive laparotomy. All the good numbers get better, all the bad numbers go down. Cardiac index goes significantly high, tidal volumes go up, urine output goes up, and there's a decrease on the bladder pressure, on the heart rate, on the central pressures, on the peak airway pressures. Lactate also decreases. Something else that is interesting for our trauma population is that it's described that on patients with a pretty bad head injury, decompressing the abdominal pressures may also help with intracranial pressures. And the outcomes on patients with open abdomen in a series of 900 patients was that, well, there was, in a basic trauma, level 1 trauma center, in a case population of 900 laparotomies, 10% were left with an open abdomen. 85% of those were able to have a definitive fascial closure, and typically within 4 days. Smaller subset needed closure with biologics or with split thickness skin grafts, or just closing the skin alone. The easy fistula rate is 15%. So a topic that may be a little controversial, actually 2 topics that may be a little controversial, is feeding the patient with the open abdomen. Actually, feeding the patient with an open abdomen has been shown to be beneficial. The reason is that it increases the splenic circulation, which will then help with reabsorption or venous drainage, which may ultimately help with the bowel edema. It has been shown to have lower fistula rates, and decrease complication rates altogether, as well as decreased mortality. I think this paper came from shock trauma from Dr. Jose Diaz, who now is in Tampa General. This is some ways that we temporarily take care of the open abdomen. In the old days, yes, towel clamps. There would be like trays with hundreds of towel clamps, in which just everything the skin gets approximated to prevent evisceration, and also as just to create tamponade. Other techniques include a Bogota bag, the poor man's wound bag, as well as the negative pressure assisted devices. This is the Bogota bag, which was described by Dr. Moraes, who back in 1980s, he was a surgical resident in Colombia, where they, as you guys know, they have big problems with the guerrillas, and they still have a pretty high trauma incidence. And they were treating with this Celastic, or this plastic bag that is really just a IV fluid bag that's sterilized and then sutured. Two prominent trauma US surgeons, Dr. David Feliciano and Ken Mattox, in 1984 went to Colombia, learned about it, brought it to the US, and back in those years, it was pretty popular in the US as well. Other techniques that have also, with different popularities, have been used include the Whitman patch and other dynamic closures like the Philadelphia technique, as well as the Abra system. This is a poor man's wound bag, in which this, when I was a surgical resident, how we contain the open abdomen. Basically, the two approaches here. We put a 10-10 drape, then a moist Curlex, couple NG tubes, put an IO band, and then connect those NG tubes to suction. Another way, instead of putting an 10-10 drape, we used to do a blue towel, wrap it on IO band, fenestrate it, and then did the same thing on top. This is a way to contain all the drainage and to keep the valves moist, and also to contain the valve from eviscerating. Now we have a company called KCI with $1 billion industry, negative pressure therapy, and we use the Apthera, which is a pretty neat, very, very neat dressing, which we're able to place in the abdomen in a pretty expeditious fashion and control the open abdomen. This is the Whitman patch that is basically as a Velcro, and it gets serially made tighter as the bowel edema subsides. This is the Abra system, another dynamic system. Another dynamic system is the Philadelphia technique that is combined with negative pressure wound therapy, and it was described by my prior boss, Dr. Sims. This is a study that is a little biased. I think that was supported by Dr. Whitman, and we show that the highest fascial closure rate was by the artificial burr or the Whitman patch. But certainly it's a study out there that shows different techniques and their benefits. Lasix. We always treat our patients with Lasix, makes us think that it's going to help, diuresis is going to help the bowel get less edematous. Study from shock trauma suggested that that's not true. It does help with the abdominal wall edema, helps overall with an asarca, but it does not help with bowel edema. Another controversial topic, I don't think I have a slide of that, is about the use of extubation on patients with open abdomen. A study suggests that it's beneficial, that there's also a higher rate of primary closure in those particular patients. Some other people argue that you have a bigger loss of the domain in that patient population. So there's numerous amounts of skin substitutes or dermal matrices out there. There's synthetics, biosynthetics. There's fish skin, there's porcine urinary bladder, there's placental matrices, there's fetal bovine, there's ovine, small intestine. They all report the claim that there's increased vascularization in the area. This is confocal microscopy in which we can see the xenograft and a fibroblast migrating through the pores of the dermis. Some of these pores are big enough to allow fibroblasts to go through, but small enough that won't allow bacteria to go through. Another agents, in order to be able to resurface these wounds a little more expeditiously, maybe suspended autologous cell transplantation, in which we can expand donor sites in a 1:80 ratio. And donor sites have been shown to be decreased in a 23%. And epithelialization maybe as fast as over 95% epithelialization within 2 weeks. I think next, we're going to show a couple of cases of loss of domain. This is a patient, a 30-year-old lady, cirrhotic, alcohol abuse. She had recurrent pancreatitis. presented with necrotizing pancreatitis, retroperitoneal abscess, multi-organ failure, septic shock, and abdominal compartment syndrome. We did a decompressive laparotomy, contained the bowels with vicryl mesh. We see a significant step off of like over 1.5 inches. We also see that the retroperitoneal abscess, despite 3 percutaneous drains, was still making its way anteriorly. This was resurfaced with a xenograft, and within 4 days, definitely wouldn't advocate to use any xenograft or any dermal matrix on a contaminated field. But in this particular case, better to be lucky than good. That fistula closed, and we see 100% incorporation of the xenograft. Just over 2 weeks, there's an ideal wound bed for grafting. And again, here the race or the time constraint is that we want to minimize the risk of easy fistulas that is reported to be up to 15% on open abdomen cases. Surgery or skin graft resurfacing was delayed a little longer because of severe anxiety of the patient, and also as she was undergoing endoscopic procedures, axial stent, to manage the retroperitoneal abscess. This is how it looked on day number 40. And the thing to note here is that there's no step off. Remember that that 1.5 inches is completely gone. Wounds act really like on steroids when being managed with some of these dermal matrices. We skin grafted it. We use sprayed skin cells, my mandatory wound vac, complete nearly more than 95% epithelialization by 2 weeks later, completely healed a month later. Right now, she's completely healed. She's losing weight. Last week, she actually underwent Botox injection and is going to have an abdominal compartment separation on the 21st of March. She's actually going to have her surgery in Boston. This is a patient that I treated in my previous institution in Ohio. She's a 50-year-old lady, the biggest nightmare of any surgeon, any plastic surgeon. She underwent an elective cosmetic procedure, a liposuction, had bowel injury, came back a few days later in septic shock, bowel injury, multi-organ failure. We did a few debridements. We can see she has absolutely no abdominal wall. Her external obliques are pretty much at the level of her anterior axillary line. All her bowels are being contained with a vicryl mesh. We placed a xenograft, mandatory wound vac, and within 2 weeks, wound bed that is optimal for a skin graft. She is completely healed, and now she's unhappy because everything is bulging. She has a big hernia, and she was referred to the Cleveland Clinic, was treated by Dr. Rosen. He tagged team with a plastic surgery team. He did a hernia repair with inlay mesh, polypropylene mesh, and bilateral ALT flaps. She had a post-op bilious, and this is her CAT scan. We see a nice pedicle flap with a good arterial supply. This is another patient with also abdominal sepsis from bowel perforation, open abdomen, obese, also polycystic kidney disease, huge kidneys, also pretty big step off. We applied a different type of xenograft. This is a fetal bovine xenograft, complete incorporation of the graft, a beautiful wound bed for grafting. We wait a little more just to get a little better contour. She was part of a clinical trial. I was the PI of a non-burn open wound treatment with a sprayed cell transplantation. This was a clinical trial patient, which led to FDA approval, and now there's a paper about it. We basically autografted it and sprayed cells. This is how it looks 1 week later. This is how it looks 2 weeks later, and this is how she looks now. She hasn't lost weight. She has 2 huge kidneys. Her abdomen is, there's no plans of doing a hernia repair. So we mentioned 50% of these situations end up in an easy fistula. It's not the end of the world, and it still be treated. Certainly, it's a big problem, and it's challenging to treat. We can still contain those fistulas with negative pressure wound therapy. There's these nice, easy fistula devices, and it looks like it's a low output fistula, right? But here we can see it's a major output fistula. So definitely with this device, it makes a whole of a world difference. You're able to graft it, and that completely epithelializes and heals, and you have a control fistula later on. At a later time, you can take down the fistula and repair that hernia. Another patient with loss of domain, which also treated similarly, skin grafted it. You know, I learned from burn nurses, which will back burns and wound nurses that will back absolutely anything and get a seal absolutely anywhere. So now there's a sort of challenging back. I say, bring it on. Let's try. Let's do it. And yeah, you're able to really contain these, which otherwise will be a big disaster and very difficult to manage. There was a younger lady that nobody wanted to operate on her. I have a pretty cool video in which you see all these easy fistulas there. All the bowel is moving. It's actually pretty crazy to see. After quite some time of lights of adhesions, you find the proximal end, the distal end, and put it back together. So, and then just to show another, what happens with those loss of domain cases later on after skin grafting it. This is a survivor. He was in Boston, shot numerous times. I want to say like 15 times. He had an ear thoracotomy extended to a clamshell, Foley catheter into the right atrium. He was really a save of the team that treated. He was treated at BMC, Boston Medical Center. Then he came for the hernia. 1 year later, that's when I met him. Get the prick sign. We wait to make sure that you can separate the valve from the skin. You could do that. Still was a very difficult, extensive case. Somehow I don't have a picture of the incision, but I could find a picture of the dressing. So you fix those hernias. And we're going to talk a little bit about how to manage those hernias. This is how, if you get a CAT scan of those patients, how a loss of the domain looks. The rectus muscle is completely retracted. And here there's like a 20 centimeter separation between the medial edges of the rectus muscle. And we can see all the all the intestines are within the abdominal wall. So back in the 1990s, early 1990s, a plastic surgeon named Oscar Ramirez published a case report about abdominal component separation. He did a release of the external oblique and also a retrorectus dissection. And that's one of the most popular techniques right now. The other more popular technique is the TAR, or the transversus abdominis release, that is basically releasing, yes, here, this fascia here. That would allow to medialization of all the lateral abdominal wall and potentially, allowing a closure in the midline of the abdomen. It's challenging to obtain that when the defect is more than 20 centimeters. It probably shouldn't be done if the defect is less than 10 centimeters. And there's multiple variants of abdominal component separations, but again, the two most widely used ones are going to be the anterior release and the TAR. In my hands, and I believe that the anterior release gives me more release, although some people claim that you can obtain the same release with a TAR release. You can obtain up to 20 centimeters at the level of the umbilicus. This is the release that you obtain in each side, 8 plus 2 centimeters, 10 and 10 centimeters. You can also do it laparoscopically. And early on my practice, I was doing them laparoscopically as well. But then I realized all these big mushroom hernias, after I had struggled and spent a lot of time doing a laparoscopic release, when I dissect the whole sac, I'm pretty much like 1 centimeter or 1 inch from that plane of dissection. So I don't really find the benefit of it. Actually, in residency also, we did a couple of decompressive laparotomies laparoscopically. I think that on those patients that are on extremities, you probably shouldn't be doing it laparoscopically. You just need to do something that is really going to decompress them. But it's described, the laparoscopic component separation and as well the laparoscopic decompressive laparotomy. The goal of any hernia is to close the defect, to medialize the medial edges of the rectus muscle. And as we mentioned, ideally, you're going to release some of the fascia laterally. Afterwards, ideally, reinforce that hernia repair with a mesh. From a study from the early 2000s, published in the New England Journal of Medicine, there's a 50% decrease in the recurrence rate when a hernia is fixed with a mesh repair. The ideal placement of the mesh is going to be underneath the rectus muscle, ideally within the retrorectus space. Potentially also it's okay in the sublate space or the intraperitoneal space underneath the rectus. But when you cannot bring the edges together, an inlay approach or even a sublay, it's also described, but as well it's less optimal. So this is how your abdominal wall should look after doing one of these repairs. The medial edge of the rectus muscle is closed. There may be a release of the external oblique or the transversus abdominis. And you never want to do both because otherwise you can create a lateral hernias. And then a pretty generous, widely placed mesh. There's 1,000 or 1,000,000 meshes out there. Additional tools or options for treating some of those more challenging loss of the veins hernias will include Botox. Botox is typically is an injection typically done at 3 areas within the lateral abdominal wall, typically within the external oblique, internal oblique, and transversus abdominis. At these 3 levels, it gets injected, again, at 3 different positions laterally on each side. In order to get the best results of more laxity, you want to wait at least 3 to 4 weeks. And the patient that we mentioned a little bit ago, that's basically what they're waiting, 3 to 4 weeks prior to getting her definitive repair. It's also reported pneumoperitoneum. I've never seen it done, but it can even be done. It can even be done outpatient. The cases that I've heard being done, the patient gets admitted to the ICU, gets like a Veress needle or a catheter placed, and you administer 500 to 1,000 mLs of air, and every 2 to 3 days you inject another 500. I understand that it hurts a lot. It's variably tolerated by different patients, but it's an option. Again, there's descriptions of this even down in the ambulatory setting. And there's also the role for tissue expanders that are placed in the subcube, and this may help expand the skin as well as the muscle. And lastly, we always depend on our plastic surgery colleagues, which can do very imaginative and creative flaps, like the one that we're going to see now, and the one that we saw in our previous patient that got bilateral ALT flaps, in which they do these rotational flaps that are able to cover pretty large defects. This is a team. As you can see, everybody's always smiling and always very happy. So if you see any of them in the hallway, make sure to say hi. You can always find us in the hospital. We're here 24/7. So if you want to talk to us, feel free to call us anytime. And we wouldn't be able to do absolutely anything without the help of this group of skilled and a passionate and sensitive and knowledgeable and caring team. Looks like the cast of a reality show, but no, these are our APRNs and PAs. It's a pretty robust team. I understand they're recruiting one more right now. There's 19 people here. I didn't know how I was going to fit 19 pictures, but I did it. And this is the rest of the team, and I'm sorry, I'm missing a lot of people, including the nursing staff, the operating room staff, all the team taking care of our case registry and working on our EGS verification. This is the Physician of the Year, recently condecorated at SMH Hospital, as well as the rest of the team that are working tirelessly to us be part of this national initiative, just to obtain better quality for all of our patients. Currently, there's only 10 hospitals in the country with this designation, and we're seeking to be the first site in Florida to obtain this designation. So kudos to this team. And again, thank you for this undeserved privilege to talk to you guys. And this is my biggest pride, Sebastian and Milan, proudly wearing their Peruvian colors and enjoying as much as they can of the outdoors of SRQ. Thank you for your attention, and I welcome many questions. And somehow I stayed right on time, 1 p.m. Yeah. Any questions? And I know we went through a lot of information, and you know, I think that definitely is a pretty sick population that is very challenging. We really try to push the envelope in order to try to save some of these patients. And again, I'm just not saying it without this multidisciplinary team doing this would be impossible. Any questions virtually? Thank you. Thank you, everyone. Thank you. How many potatoes are out there? There you go. Mission accomplished.
You guys might want to screenshot that if you didn't already for the CE credit. Thank you guys so much for coming.
can work with butter.